We shall now go on to our last speaker, Dr. Venkatesh, who's a Chief Medical Officer and Chief of Glaucoma Services.
Okay. Thank you, madam. Thank you for having me, and we'll try to finish in another 6 minutes now.
Gateway to Safe GAT, Gonioscopy Assisted Transluminal Trabeculotomy, or GAT, the brainchild of Dr. Devender Grover and Dr. Ronald from Glaucoma Associates of Texas, Dallas.
Dr. Venkatesh, we are not seeing this screen.
You're not seeing? Okay, let me try again. Can you see now?
Perfect, sir. You can continue, please.
It's an ab interno canalization of Schlemm's canal to create 360 degrees of trabeculotomy. Conventionally done with an illuminated microcatheter, the low-cost option is by using 5-0 proline suture. Here are the must-have items for performing suture GAT: 5-0 proline suture, low-temperature cautery, direct Swan-Jacob gonio lens, high viscosity ophthalmic viscosurgical device (OVD) like Helon GV or Orogel, 25 gauge MVR blade, MST forceps, indirect gonio prism, McPherson's forceps. An ideal suture GAT surgery involves the blunting of the tip of the 5-0 proline suture using a low temperature cautery to make small flange at the tip. Following this, the suture is introduced into the anterior chamber under OVD. A small 1 clock hour initial goniotomy is made in the trabecular meshwork using the 25 gauge MVR blade. Then, the flange suture tip is introduced into the Schlemm's canal using MST forceps under Swan-Jacob gonio lens visualization. With gentle strokes, the proline suture is advanced gently into the canal till it appears from the opposite side, where it is grasped at the tip above the initial suture and brought to the center of the anterior chamber. Finally, using a McPherson's forceps, the external suture is pulled out, creating a 360 degrees ab interno trabeculotomy. We share here some beginner's complications, and we will also focus on some tips and tricks to avoid them. Positioning and seeing the angle. Initially, during intraoperative gonioscopy, one will have air bubbles or too much pressure, which can result in indentation and failure to see the angle properly. But with practice, one can master this skill. A thorough pre-operative slit lamp gonioscopy with special attention to the nasal angle is very important. Initial intraoperative gonioscopy can be practiced on routine cataract cases before initiating or after completing the case. Tilt the patient's head 30 to 35 degrees away from you and tilt the microscope 30 to 35 degrees towards you. Put a drop of OVD on top of the cornea and gently place the Swan-Jacob gonio lens over this drop. Adjust the microscope magnification. Start from a lower magnification and then slowly zoom up using the microscope foot switch. Routinely practice the foot switch of the operating microscope as both the hands get engaged while doing MIGS, so finer adjustments need to be done using the microscope foot switch. Ideal flange. The tip of the 5-0 proline is blunted to form a small flange using low temperature cautery. This is to make the tip atraumatic and facilitate its smooth passage in the Schlemm's canal. Tip: keep the low temperature cautery a little away from the tip to get a just needed flange. If cautery comes in contact with the suture, the flange is too big for the size of the canal. It will result in difficult entry into the canal and may also create a false passage. Tip to avoid false passage. In addition to a perfect flange tip, there is another way to ensure that the suture is in the canal and has not taken any other path. This is to perform an indirect gonioscopy on table using a sterile single mirror gonio prism. The blue color of proline helps in identifying its presence behind the trabecular meshwork that is in Schlemm's canal. This will also give an idea as to how many clock hours have been traversed and how many clock hours are left. Direction of the tip should be circumferential rather than perpendicular to the goniotomy. What happens if a false passage is created inadvertently? The suture tip can go into the suprachoroidal space and cause a choroidal detachment, which can be managed conservatively with oral and topical steroids and resolved within 15 days. Reduce bleeding from conjunctiva and Schlemm's canal. Make the incision on the clear cornea to avoid any bleed from conjunctival vessels, as this can result in poor visualization. And there are a few tips to avoid reflex bleeding from Schlemm's canal while making the initial tear in trabecular meshwork. Keep the patient's head above the heart level by lifting the head end of the operating table. Fill the anterior chamber with high viscosity OVD like Helon GV or Orogel. Partial or semi-GAT. As the proline passes through the Schlemm's canal, resistance is experienced when it reaches 180 degrees as it has to turn the other side. It is an indirect sign that the suture has reached 180 degrees, but sometimes it doesn't proceed beyond this point. Tip in this situation: try twin side GAT, which means threading the suture in clockwise direction rather than the initial anti-clockwise direction. Leave it at the site of resistance. Try to localize the suture using indirect gonioscopy on table. If the suture has reached 270 degrees, then try to make a small nick at that site and retrieve the suture. By implementing these tips into routine practice while performing GAT, one can achieve desirable results. It requires practice and perseverance to master suture GAT, but these tips can ensure a safe gateway to successful GAT. Thank you.
Wonderful presentation, Dr. Venkatesh. Your videos are always truly amazing.
Thank you, madam.
Can
We
you
thought
take-
we'll share the tips and tricks so
Yes,
that
very nice.
more than the complications, it's people
Yes.
can be benefited. Yeah.
Yes, Murli, can you take a question before we conclude?
Yeah, sir, how significant is the episcleral fluid venous wave in predicting success of GAT, sir? Like in trabeculectomy, you have so many adjustments you can do in the postoperative period, but in GAT there is nothing. You just have to wait and hope that the pressure falls. Just in case the pressure fails to drop, how long can you wait before recommending either additional medical therapy or further surgery?
I think it's again a matter of time only. During the post-operative period, at least 2 to 3 months period, it usually stabilizes with your steroid response. Sometimes you get microhyphemas, which can again raise the pressure. So you'll have to wait and watch. Maybe in between you may need anti-glaucoma medications also. But to see a good effect, it minimum it takes 4 to 6 weeks, and then you can really assess. And after a certain time, definitely after 3 months, you'll know whether it's really working or not.
Yes. Anything else from the expert panel before I conclude? I think you all can switch on the screen when I can have a proper look at all of you and express my most heartfelt thanks for the wonderful webinar which we thought, but it got created by only each and every one of you. It couldn't have been anything better if each of you had not delivered such a wonderful series of talk. And thanks so much to the expert panel. I know I could ask any question and I would get the bang on just the answers which I need. I think we should have utilized Dr. Craig's contributions a lot more, but I think we were running out of time. Thank you so much, Dr. Craig, for you being there, Dr. Harsh, Dr. Shushmita, Dr. George, Dr. Venkatesh, Dr. Vidya, Dr. Devang, and Dr. Sati, and Dr. Ronnie George, each and every one of you. Thank you so much. Thanks to my ARC colleagues who are always there to support me. And it goes without saying, I really need to thank my co-moderator Murli, who's such a solid block of support for me at all times and helped me wade through this tenure of ARC with a lot of support from him. And I need to thank my AOS admin, Mr. Kripal, and all his team. Need to thank Sai, who always fills up your inbox. I do hope you all always remember me only with a smile and not as a person who sent so many mailers to all of you. And I definitely need to thank Mr. Sunil. As you can see how brilliant and efficient he is in ensuring that the webinar runs very, very smoothly. And believe me, we really owe our thanks to Entoad. They have been such a phenomenal support for all our ARC webinars. And I was talking about physical meetings to add on. They said they are always there for us. So, that sort of encourages me to think unidirectionally towards academics and not overly worry about how I would go about getting the sponsorship. Even CIPLA has come forward to help me in my few of my physical meetings. But I do hope that you all believe, as I believe, that a lot of learning comes through the webinars. I just wanted to ask you all whether you all feel as similar to me, or you all feel that it's only the physical meetings are the way to go. No comments?
Tough question, madam. We should know on the other side how many people are seeing, because sometimes most of the speakers, they don't know. You know, actually, because you are in touch with the admin.
No. It was something like early days, 1,800, 1,500, then 800 and all. But nowadays it is 400, 500 and all that. And so, I think, and more importantly, it's on that day, but over the days, I would actually share with this group over the days and the months, the kind of people opening and viewing some of the important topics and their needed topics is truly very, very heartening. So I think it has its role now. I think it was COVID's blessing besides it all. Anyway, thank you so much. Thank you very much for the wonderful webinar. Thank you.
Thank you, madam. Thank you very much.